Gold standard in diagnosis of carpal tunnel syndrome is abnormalities in electrophysiological studies in correlation with the spatial symptoms. Electrodiagnostic studies can also identify the severity of carpal tunnel graded into mild, moderate, and severe. High-resolution ultrasound is widely used nowadays in assessing different musculoskeletal structures, especially in imaging of peripheral nerves. It is widely available, cost-effective, radiation-free, and less invasive than other techniques and electrophysiological testing. It also helps to differentiate idiopathic carpal tunnel syndrome from secondary carpal tunnel syndrome due to tenosynovitis in the flexor tendons, tumors, or ganglia. Sonoelastography is also an emerging technique. It is used as a simple non-invasive technique in assessing tissue elastography and can measure tissue stiffness. It is divided into shearwave and strain-wave elastography. Strain-wave depends on external pressure applied by the operator, while shearwave depends on ultrasound machine itself. In the study, we aim to explore the diagnostic performance of several ultrasonography and elastography parameters in diagnosing and grading the severity of carpal tunnel syndrome in correlation with the electrophysiological studies on the median nerve. It is a case control study conducted on 62 rats. 31 served as cases and 31 were controlled. 31 cases were referred to our radiology department from the Department of Neurophysiology after being clinically diagnosed and confirmed by electrophysiological testing. We included the patient who have clinical symptoms of carpal tunnel syndrome, such as pain, swelling, paresthesia, numbness, and weakness of the hand, sensory deficit or atrophy of the thenar muscles. And they were confirmed to have carpal tunnel syndrome by electrodiagnostic studies. In the study, we excluded those patients with history of wrist or hand fracture, previous carpal tunnel release surgery, and neuropathies such as diabetes, polyneuropathy, and hyperthyroidism. Patients were asked to sit facing the examiner with relaxed upper limb on a pillow and forearm in a supine position. The fingers were held in a relaxed position where they are semi-flexed. The patients were instructed not to move their wrists or hands during the whole examination and to avoid any wrist or hand position which will increase the compression and increase the carpal tunnel syndrome, carpal tunnel pressure, producing false results. Regarding the patient method data, we recorded patient demographics, including the patient age, sex, laterality of the wrist, degree of severity as stated by the electrophysiological study. Then we recorded the following data: median nerve cross-sectional area, delta cross-sectional area, vascularity, shearwave elastography. Regarding the median nerve cross-sectional area, the median nerve was obtained in a transverse axis at the level of carpal tunnel inlet, and the margins were traced, such as the hypoechoic rim was excluded. Then it is obtained, the measure was obtained in millimeter square. Then the median nerve was measured at the level of pronator quadratus muscle, and delta cross-sectional area was calculated as the difference between the nerve cross-sectional area at the level of pronator quadratus and its cross-sectional area at the carpal tunnel inlet. Wrist forearm ratio, by measuring the median nerve cross-sectional area in the forearm about 12 centimeters proximal to the distal wrist crease, then a ratio between its cross-sectional area at the level of carpal tunnel inlet was calculated. Vascularity was applied by Cullen Powell Doppler to detect any vascularity. Then shearwave elastography was done. The probe was rotated 90 degrees and the nerve was obtained in the longitudinal axis. Region of interest was placed on the median nerve directly at the level of the lineate bone. Automatically calculated quantitative stiffness in kilopascal was obtained. Study was performed using Toshiba Ablu 500 with linear probe 7 to 14 megahertz frequency. Regarding the results, the patient age distribution ranged from 23 to 65 years, with the most common age being between 20 and 49 years old. The detailed measurements of values of our parameters across the cases of control will be shown in the following table. Regarding the median nerve cross-sectional area, the mean value was 14 for case group and 8 for control group. Regarding delta cross-sectional area, the mean value was 7 for for case group and 2 for control group. In the case group, the rest for arm ratio was of mean 1.95, and in control group was 1.26. Shearwave elastography mean value for case group was 84.5, and in control group was 38.0. Vascularity of the median nerve was detected in 16 patients, about 51% of the patient, while no vascularity was detected among the control group. They all have statistically significant p-value. Regarding the parameters, we make the cutoff value for different parameters to differentiate those cases from to have carpal tunnel syndrome. Regarding median nerve cross-sectional area, a cutoff value of 9.8 with sensitivity 87 and specificity 83 was used to diagnose carpal tunnel syndrome. Delta cross-sectional area cutoff value of 2.6 with sensitivity 90% and specificity of 83% was used to diagnose carpal tunnel syndrome. Rest for arm ratio cutoff value of 1.3 with sensitivity 93.5 and specificity 71. A cutoff value of 51 kilopascal Shearwave with specificity of 96 and sensitivity of 100% was used to diagnose carpal tunnel syndrome. These parameters were able also to significantly predict those severe cases and differentiating them from mild and moderate cases with the following cutoff values. Cutoff value of 14.5 in median nerve cross-sectional area with specificity 84% and sensitivity 100%. A cutoff value of 8 in delta cross-sectional area with sensitivity 100% and specificity 80%. For rest for arm ratio, a cutoff value of 2.4 with specificity 96.2 and sensitivity 100%. Shearwave elastography cutoff value of 106 with specificity 96 and sensitivity 100%. All these values could predict the severity of carpal tunnel syndrome. Correlation between ultrasound and elastography parameters with the electrophysiological studies. These mean values were found among the mild, moderate, and severe cases. And for mild cases, median nerve cross-sectional area 9.8. For moderate cases, median nerve cross-sectional area of 15.2. In severe cases, 20.9. Delta cross-sectional area in mild cases was 3.4. In moderate cases, 8.2. And in severe cases, 12.3. For rest for arm ratio, in mild cases was 1.5, in moderate cases 1.9, and in severe cases 2.9. Shearwave elastography in mild cases 61.9, in moderate cases 89.2, and in severe cases 126. They all have statistically significant p-value of 0.001. Regarding the cases, this first case is a female patient, 40 years old, with no complaint. It is a control case. P-mode assessment revealed the nerve in transverse axis with normal cross-sectional area measuring 0.09 centimeter square. B-mode assessment in longitudinal axis revealed the nerve of normal echogenicity and normal fascicular pattern. On applying Shearwave elastography, the image on the right side is the B-mode image, while the image on the left side is the elastography image. In B-mode, the left image shows the elastography of the median nerve with color-coded bar or using a circular ROI and Shearwave value of 41 kilopascal. This is the color-coded image, and this is the square image. Case 2. Patient 24-year-old female complaining of pain and paresthesia involving the lateral 3.5 fingers, referred to her forearm. The nerve conduction studies revealed mild entrapment of the left median nerve at the level of the wrist. Regarding examination, B-mode assessment of the left median nerve in transverse axis shows cross-sectional area of 0.01. B-mode for the nerve in longitudinal axis shows the nerve normal echogenicity and normal fascicular pattern. While the Shearwave elastography shows increased stiffness of the nerve measuring 62.5 kilopascal. Case 3. Okay. Okay. Case 3, the 35-year-old female patient complaining of pain and paresthesia involving the lateral 3.5 finger with swelling full of objects out of her hands. Nerve conduction studies revealed severe entrapment of the nerve, median nerve at the level of the wrist. B-mode assessment revealed the nerve to have increased cross-sectional area, markedly increased cross-sectional area of 0.37 centimeters square. And B-mode also shows that the nerve was swollen and hypoechoic with increased vascularity. Shearwave elastography revealed increased stiffness of the nerve 100 kilopascal. Case 4, a 30-year-old male patient complaining of pain and paresthesia involving the ring and middle fingers. An electrophysiological study shows moderate entrapment of the left median nerve at the level of the wrist. B-mode assessment in the nerve in TS shows cross-sectional area of 0.11 centimeter square. And B-mode shows that the nerve has normal echogenicity and normal fascicular pattern, while the Shearwave elastography shows increased stiffness of the nerve 85.3 kilopascal. Finally, we concluded that the ultrasound and elastography can be used in diagnosis of carpal tunnel syndrome severity. Also, they can be used in grading carpal tunnel into mild, moderate, and severe. Using this non-invasive technique, which shows the highest specificity and sensitivity in diagnosis of carpal tunnel in correlation with other studies.
شكرا يا نوران على النايس برزنتيشن. دلوقتي هتقدم دكتورة دينا عبد الله، مدرس في اسم الأشعة. عنوان المحاضرة على الرول اوف chest ultrasound in evaluation of chest trauma patients. اتفضلي يا دينا.
السلام عليكم ورحمة الله. إن شاء الله هنقدم presentation عن role of chest ultrasound in evaluation of chest trauma. Chest ultrasound is a bedside, reliable, dynamic, rapid, and non-invasive technique. It can overcome difficulties involved in examination of children and uncooperative patients. It's superior to chest X-ray and CT